Hello, everybody, and welcome to the Clearly Aligned podcast, coming to you specifically from Las Vegas, from the Bellagio. Now, I get the pleasure of inviting a special guest on today, where we have Dr. Lovedeep Randhawa. We were just going over if I'm actually going to say the last name properly, so I think I got it.
You nailed it. It was perfect. Thank you so much, Stephen.
And I've known you, Lovedeep, for quite some time.
Yes.
And so it's really cool to be able to have these opportunities where we jump in and talk more about not just clinical, which we'll talk about in a moment here, but to talk more about like life in general and goals, strategies. Like that's the goal of what we want to do with these podcasts. And so I think it's super cool. So thank you for coming on with us.
My privilege, seriously. I'm humbled that you asked me to do this, and any opportunity I get to spend time with you and chat with you is amazing.
Yeah. Now, for those who might not know, some of you might be here at Summit right now, but some might not. But unfortunately, Align put a number of the Canadians speaking for their Summit talks at the exact same time. So Lovedeep and I just both finished our Invisalign talks. And so unfortunately, I did not get to hear Lovedeep talk because I was on stage as well. But we are going to be picking her brains for the pearls from her lecture as to all the different components of ortho-restorative, of workflow, and of how she's been able to achieve such a high standard of treatment for her patients for now. How many years have you achieved platinum status?
Platinum since 2018.
So 2018.
Yes, but I've been practicing dentistry since for 20 years, since 2004. But I started doing Invisalign in my practice in 2017.
2017. Very cool.
Yeah.
Awesome. So I like to start off some of these interviews by finding out what makes you tick. Like what gets you excited, gets you up in the morning and gets you going. Like why do you do what you do?
You know what? I really sometimes feel that it's such a blessing that we have the profession that we have. And the funny thing is, I didn't even pick it for myself. After grade 12, I wrote my entrance exams and I got into sciences. And so my dad and I had conversation and he goes, you need something that's like go, 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 right? That keeps you really motivated, but challenged as well. And I said, I want to make an impact as well. I knew I was going to go somewhere in healthcare, but I wanted to make an impact as well. And dentistry just seemed so intriguing because it's not just about taking patient out of pain or improving their quality of life by making sure that their occlusion is balanced. It's also about giving them confidence, right? So that sounded very intriguing to me. And that's how I entered dentistry. And I am so thankful that we made that decision, me and my dad, because it is the best job that I could have ever had. Like, it is so nice. When I walk into the office, it's like fun time. Like, this is where I belong.
So what would you have done if you didn't get into dentistry? Did you have another plan or another thought? If you didn't do anything in healthcare, what would you do?
I would have probably it would still be healthcare. I would probably gone into surgery.
Okay.
Yeah, general surgery.
Gotcha. So you always knew you want to be in healthcare and helping people. And like you said, you've been practicing for 20 years now and doing orthodontics for many years. Talk to me more about your passion and what you're doing now in practice, utilizing Invisalign, utilizing more complex treatments to help your patients.
Yeah, it means when I first started out, of course, I was only building on what I had learned in dental school. And the more you do dentistry and the more CE you take, more I realized how little I knew and how much more I needed to learn. And as I learned more, I realized that a lot of times I wasn't really going to the foundational or the basic issues in the patient's oral health. And if I could get to that and actually treat the root cause of what has caused this avalanche or snowballing of different issues coming together and now leading to patient's chief concern, means wouldn't that be awesome, right? Then I don't have to think about the treatment failing or having any complications. And really seeing how clear aligners can help me achieve that. Mm-hmm. We talk about occlusion all the time. Mm-hmm. In dental school, we talked about occlusion. Oh. In orthodontics, we talk about malocclusion. So it all comes down to occlusion. And if I can actually put the occlusion where I want, before I get started on my restorative treatment, then that gives me the best control that I can have over the treatment.
Yeah, and I think what's so interesting is that when you look at the two lectures that we did, yours
Yes.
being ortho-restorative and mine being mixed dentition treatment,
Yeah.
it's interesting how you see that snowball effect and you see everything related, because at the beginning, when you see these kids at 7, 8 years old and they've got a deep bite,
Yeah.
the thing that I truly believe dentists don't understand, and if they did understand it, every single doctor would be platinum or diamond doctor,
Yes.
is malocclusion in kids is so significant and damaging to their teeth that I can show slide after slide after slide of 8-year-old, 9-year-old, 10-year-old who's got chipping damage and wear on their teeth. And because of that chipping damage wear, when they grow up, they need the restorative component.
Exactly.
And so it's unfortunate because in a perfect world, we wouldn't have to do any restorative. We would have maybe some lateral incisors would get built up at the end of these kid cases, but we would be in such a good position and it would not be a world in which restorative is needed afterwards. But I know specifically in our practice, when we're treating adult patients, about 80% of them, we're doing restorative at the end of the process.
Yeah.
We have lots of different systems and strategies, which I can talk about in a minute, but I want to hear from you. So let's take it right from the very beginning, right? I think a lot of doctors who might be listening might be saying, okay, like, I get it, Stephen, I get it, Lovedeep. Yeah. Like, there's the damage, chipping the wear. Like, we know all those things. Can you give me some like practical workflow? A patient comes into your office and they have damage to their teeth. They're coming in maybe for a hygiene visit or a new patient exam. Do you have any specific pearls, strategies, workflows that you have learned over the years that have really like been crucial points?
For sure. And I actually 100% agree with what you just said. If we could prevent the disease from happening, that is the best dentistry we can do for our patients, right? So you nailed it right on the head, starting early so that we don't have those problems. But yes, for my practice, every patient that comes in, once the patient is checked in, the clinical staff member will welcome the patient, bring them in. But before we seat the patient in the operatory, we actually go, my practice is very tiny. Yeah. It's like a 1,300 square foot 4-op. So
you're practicing in a cave.
It's in a cave, seriously. I don't have room to set up for a photo studio or this and that. So what we did is the door that leads to the staff room, we painted the back of it like matte gray, kind of black. And so that's where I have like a little ring light set up. So the team members take the patients there first. So we're very aligned digital platform based. So we use our IPA, our Invisalign Practice app, and my team members just take 4 extraoral photos, one wide
and
smile.
This is every patient?
Every patient that comes in. Yes. As long as if they've had it within the last 6 months, then maybe not. Yeah. But annually, we want to make sure that every patient, doesn't matter if it's coming for a spec exam, it's coming for a hygiene check, if the patient's coming in for any kind of examination. So we do that, and we do a smile video.
Okay. And what are the 4 photos you take?
4 photos are interior profile without smile, then the lateral profile without smile, then a normal smile so that I can see their normal gingival display and incisal display, an exaggerated wide smile photo so that I can use it in my simulations to communicate with my patient. And then we record a 15-second video of just patient excited about something. We know our patients really well. It's like a very small practice. Patients are like family. Like we know what they did last visit. After last visit, like, hey, how'd it go? And they're excited and they're talking about it.
Sure.
And we capture that video. Then the team member takes the patient to the op. Okay. And that's where they do the x-rays if they're required and a scan. And once that's done, patient now tells us what the chief concern is. And as the team member is also looking at the scan and is listening to the patient, they can start to kind of correlate what is happening here. But the main point of the scan is not to make a diagnosis right now or give treatment plan. So when I come into the room to do my exam, after I've done my clinical exam, I see the patient up and then I say, okay, well, let's look at your intraoral scan and see what we have there. And it's a co-discovery where, like how you and I are sitting, we are equal. I'm not an authoritative figure with like mask on my face and patients lying down. And, it's hard to communicate like that. Sure. And then we're co-discovering things together, right? Yeah. So this is where in my mind, I'm also making my evaluation. Narrow arches, omega-shaped arches, deep bite. Am I dealing with an open bite? Class 2, class 3, what's going on? Complexity of this case. But this is not what I'm showing the patient. So we're talking about tooth health, gum health, bite. I go through my align oral health suite. And then in the old days, we used to show a regular model and say, this is what their teeth should look like, or I would draw on a tray liner. I don't do that because you can't relate, right? Then we go to our simulation, Invisalign Outcome Simulation Pro. And that's when I showcase the patient that chipping that you have right now. If we actually move the teeth in the right position and give the space, we wouldn't have this chipping anymore. Whatever's happened has happened. Let's just make sure it doesn't happen further. And then to, answer, to your chief concern, which is chipped teeth, then I can do the restorative. But if I do the restorative, we don't want to put the cart before the horse. If I do the restorative now, well, if God's created enamel or nature's created enamel that I take a diamond bit on my drill and run it at 200,000 RPM to cut that enamel, if that enamel didn't stand a chance, there's nothing man-made that's going to stand a chance if the bite is traumatic, right?
Totally.
So once you show that to patients, then patients really do connect because they see their face with their atraumatic bite, their restorative outcome. And I think that's the way really to educate the patient. It's all about empowering the patient and educating.
Yeah. And maybe I'll jump in just with some thoughts, some things that you said that I think were really interesting. A strategy that I've heard of in practices is in a small space is that having the door to like, depending on which way the doors flip, but you could actually paint one door black and the other one white to the inside of the staff room. So as they open the door, if it opens out into the hallway, if that's the direction it goes, then you could have a white backdrop or a black backdrop, or have like a pull down screen higher up that pulls down. So there's so many good strategies of how people can be creative to have that proper photo.
Exactly.
But I think it shows intention when a good series of photos is taken, not with a patient sitting in the chair with a computer behind their head, and laying back with the head out. Fred Foy was talking about that today, like you're seeing up their nose because you're not getting the right angles. Doing it consistently with quality, first of all, shows that skill and the proficiency. I think we think so frequently that patients are going to be like, why are you doing this? Or this is different. But when I go to my optometrist and they look at my eyes, and they have the little airplane flying across the screen that I focus on and the little puff of air in your eyes. And then they go ahead and they're doing a new picture. Do I really think about the fact of like, wait a minute, I've had 3 of these 4 different things taken, but what's with this 4th one here, right? It's not like the scan is uncomfortable or painful. So I think that we as clinicians and as clinics, we overthink the fact that like patients are going to think, oh, you're taking this scan because you're trying to sell me something. In my opinion, I don't think patients are doing that at all. Especially if they're not being charged for this health scan. But again, what you were mentioning there that I think is so valuable for doctors to take away from this is, to me, the most important thing is the problem.
Yes.
And then the solution and the method. And so the worst thing I have ever heard said, and that sounds very aggressive, maybe not the worst thing ever said, but and I think you're probably the same way, is when somebody as a practitioner comes in and says, and we have these patients coming to our practices, they're like, why did you leave? Oh, well, they tried to sell me Invisalign.
Yes.
And it's like, well, wait a minute. Okay, tell me more about it. Well, they said I need Invisalign.
No.
Well, nobody needs Invisalign. Like, you could choose to maintain poor malocclusion, but this patient has a problem. The problem is the chipping, the damage, and the wear. Too frequently, I feel like practices say, you have a problem. You need Invisalign. That's the number one that I hate. You don't need Invisalign. You could leave this. You could live completely fine, chipping and damaging your teeth, and then eventually take them all out. Like, that's your autonomy. The second thing is that you need, you have a problem, sorry. And your problem is that you have a malocclusion.
Yes.
What does that mean?
Exactly. What does that mean? Yes.
Like, you have a malocclusion, you have a deep bite. You have an open bite, you have a cross bite. Like, people are like, okay, cool, thanks, Doc. The problem is that you're chipping your teeth, you're damaging your teeth, and you don't need to go looking for problems. Literally anybody who has a malocclusion, if they have crowding, if they have a deep bite, if they have a constricted arches, they're going to have chipping, they're going to have damage, they're going to have wear. And so I think the way that you're putting this for your patients, by having that consistent scan, by having those photos and integrating it. And then the last thing that I think you just had that I really love and want to reiterate is just having the iTero scan with the simulation in their face to see the no change. This is what you look like right now in your face. And then the middle one with, here's the chipping damage, where but your teeth are straight. And then here's the restorative. But can you talk about, when you first started implementing this, did you have pushback from your staff about scanning every patient?
I did. For them, it was that we are going to scan only patients that are interested in Invisalign. And I think that was something that I had to kind of reiterate to them. Okay, it's not about doing Invisalign. Let's just say if a patient needs a bridge, right? And when you guys are asking me, okay, doc, which was, so, okay, it's from tooth number 13 to 16. Then what do you ask next? Do you need core buildup? Are you going to need any crown lengthening? Are you doing any gingivoplasty? I tell you all that. That's a treatment plan that goes to the treatment coordinator. And those are the codes and the treatment plan presented to the patient. The patient can't say, well, okay, can I get the bridge, but not the core buildup? Can I get the bridge, but I don't want gingivoplasty or crown lengthening? No, if you want the bridge, this is how it goes. So the thing is, if I want to get to a bridge or an implant or crowns on a patient or restorations on patients, and one of the treatment steps sequence is Invisalign, then that is just how I'm going to get there. The end result is the treatment that the patient wants. How I'm going to get there is the way I'm going to show you how I'm going to, you know.
And so did you have those conversations then with staff?
With the staff. And I explained that. I said, we're GP practice. We're restorative dentists. For you, when you're doing a scan, that is for me to get all the records. So when you don't question me for pen, you don't question me for bite wings, I'm going to give you extra time. So when we first started out, every time that we had to do a scan, I added 10 minutes to the appointment. And that was fine. We were not charging patients and we were not, you know, the team was getting extra 10 minutes, which means, yes, the production did suffer a little bit. But did it really? Because out of that, if 2 patients understood the value and actually gave me the freedom to treat them the way I wanted to treat them, and then patients and the staff seeing the outcome, means that just build the confidence in everybody, right?
Yeah.
So I think for me, the team feels empowered when they see these outcomes that we get for our patients, and they're so proud to share with the patients and almost have like a patient library where like, oh, we have another patient like you. Sometimes I'm not in the office. I'm lecturing. I'm traveling. And then I have cases that are being uploaded to be done. And that's because the team believes that that's the best way to get the patient where they want to get.
Yeah, absolutely. I think what you hit that I really like is just the empowering of the staff. And here's the reality. To me, it's if we don't show our staff the why, they're never going to get on board. They're going to say, well, you're doing a scan because you want to do Invisalign. But the reality is, like, and it sounds a bit maybe blunt to say this from my side, but like, I honestly do not care for these patients if you do Invisalign or not. I don't care, right? Maybe I'm more jaded than other people, but I don't care because my goal is not to tell you need to do Invisalign or that you have a problem and you need to fix this. No, my goal is just that. I want to tell you what's going on with your teeth. I want to tell you the problem. I want to tell you the solution. I want to tell you what your options are. And if you choose to do it, that's fantastic. But if you choose that you don't want to do any of this, I got a patient the other day who said, you know, I don't care if I lose all of my teeth. My grandpa had dentures. My mama had dentures. I do not care. And it's like, well, great. Like if that works for you, then that's the thing that is most valuable. But for our staff, the standard of care, I tell them that the one thing that will constantly change in our office is that there will be constant change.
Yes.
Right? We do not want to be that practice by the end of our career where we say, you know what, we did the best of 2020 dentistry in 2050. Just like right now, you wouldn't want to say, hey, we're doing the best of the 1990s dentistry in 2020. So I think that really setting those goals and explaining the why, you can have as many incentives as you want. You can put people in the phone booth with money flying around for the staff to grab every case start, and it's not going to make any difference if they don't understand that we do this. And that's why I think it's so interesting when you say your why. I always ask this because why do we go into dentistry? Well, we go into dentistry because we want to help people, ultimately.
Yeah. Ultimately, that's the goal.
That's the thing. And so why do our staff, why do our hygienists, why do our assistants go into dentistry? They want to help people. And so if that's the case, how does an assistant or a hygienist respond when they say, no, I don't want to scan. It's too much work. It's too much time. They're really just hesitant because it's something new. And inertia is hard to break. Momentum of being still is hard to break. Just like once you get that momentum going, everything flows so beautifully. But you have to break that momentum in order to get them going. And they're just hesitant and scared that it's going to be something they're uncomfortable with, or they'll do it poorly, or it's not going to be, you know, it's one of the flash in the pans that we brought them to the practice before and didn't do. And so if we can help them understand that the why we're doing this, we are not scanning our patients to do more Invisalign cases. We are doing it to educate our patients and increase the standard of care that we're giving them. I think then you can layer in incentives and goals on top of that to help give your staff something that's enjoyable and fun, but it can't just be like,
No.
you know how it is, right? You
No.
have to make sure that they understand the why, or else without the why, nothing else, it doesn't follow properly.
No, you're 100% right. Like, I think the staff feels the stress of the environment if what they feel that's being done in the practice is not really leading to the best outcomes for everybody, right? So yeah, they're healthcare providers, and they need to know that they're part of providing that good healthcare for the patients.
Totally.
Right?
Yeah, for sure. So you got to the point now that the patient's scanned. You're now able to have those conversations with the patients. What comes next in your practice? How are you now transitioning these patients when you're actually in treatment? Let's talk about that time point.
Yeah.
Are you finishing their case? Are you taking off all their attachments? And then are you holding them in a Vivera or an Essex before the restorative? Or do you take off all the attachments at the same time? Talk to me about like some really nerdy clinical details, some pearls that doctors right now would say like, okay, that's really good info.
So now, as you know, we have Invisalign Smile Architect. So that's made our life so much easier. Like, can you imagine or remember how we used to do it before? You would do the orthodontic planning, and now you have the end result of the orthodontic. Then you scan that. Now we are going to set up the restorative case, and we have to do restorative planning. And sometimes you go, oh, if only I had moved this tooth this way, right? What my goal is to be minimally invasive, right? Now we know what we can't replicate what nature gave. So we want to preserve, and that's the whole thing. If we are preserving, we don't want patients to chip teeth. We want to preserve as much enamel as they have. Now, when I know what the outcome should be, the restorative outcome should be for the patient in Invisalign Smile Architect, I take time to actually plan my restorative. I use the 3D controls. I use all the tools. I set up my restorative just like I would be doing a wax up for a case, basically, right? Once I'm happy with that and I'm happy with where the occlusion would be with that, then I start to move teeth into those restorations, also knowing what kind of material I'm going to be using to restore this patient, right? If things change over time, sometimes in life happens, and patient might, that wanted to do veneers now want to do bonding. But still, with as much information as I have, now I know the material thickness I need, the shade of the teeth. I know how much opacity I need to add in those materials. So I can now move teeth into this restorative, right? And then that restorative design, not in the beginning, I save that restorative design. Obviously, it's saved on our ClinCheck. But when the patient comes in after the first active aligners are done, before we give them the passive aligners, we evaluate. If we are where we want to be, great. Now we're going to send this restorative design to the lab, and we're going to actually get started. We're going to give them the passive aligners. They're going to come back. We're going to remove attachments. We're going to do the mock-up because we already have a restorative design. We 3D print in my practice as well. So we print the models, do a quick matrix. We do the mock-up in the patient's mouth.
So you're doing mock-up too?
Yeah. Mock-up in the patient's mouth. And the mock-up I do because the day that I'm doing the prep, I actually book the first 45 minutes is just so the patient is calm and we're finalizing everything. That's when, before giving anesthesia, before lying the patient down, I'll do a mock-up. Patient can test drive that. We can make any changes that we want to make to that. If I'm changing the shape of the tooth because the patient wants that and patient's happy with that, we'll rescan that. Because I want everything
so
and gone
talk to me about, patient comes in, you have the shape of the teeth. They say, no, those look a little too square. I want them more round. Because you're doing this the same day as your prep appointment.
Yes.
So then now take me through that moment. I don't like the shape. I want more rounded. What do you do now?
So, sorry. Let me go back a little bit. So when we decide that now we are giving them the passive aligners because we're booking them back in 4 weeks or 5 weeks, because sometimes we need to do bleaching and stuff too, right? So we're kind of timing all that. At that time, I show them the in-face visualization. That's the only time that I really show them the ClinCheck with Invisalign Smile Architect, because otherwise they don't need to see that. So at that time, if this is very close to what they want, then that's great. If they want us to make any changes, then I can make those changes, do a refinement, not really get those aligners, but copy that shape into my restorative model, right? And so we already...
And you're using the STL then from your actual Invisalign Smile Architect plan?
Yes. So you export that and you print it, and then you can do either a suck down or putty template, whatever works in your practice, right? And then because it's going to be mostly additive, you're going to be quite accurate, right?
Yeah.
Like if I hadn't moved teeth into the position and I had to do reductive, mock-up isn't going to be the best.
No.
You're not going to get
Oh,
the best
I
result.
remember those in our practice where
Yeah.
you're doing a mock-up and the teeth are all like beaver teeth out so far they can't close their lip.
Exactly.
You're like, no, don't worry.
This is not how it's going to be.
Actually, it's just
Yeah. I never want to do something that makes the patient doubt
Taking
anything, right?
And you're blacking out the incisal edge of some of these teeth. Yeah.
So now because it's mostly additive, it's so nice. And you can check the phonetics.
And what percentage of time when you're doing these mock-ups for patients do you do the mock-up then, and now you're chairside and you are putting it in?
Yeah.
How often is it like 100% of the time that they're like, love it, versus what percentage of time is there someone who says like, ooh, I don't know, it's a bit too square?
You're always going to have those patients.
Oh, of course.
Right?
Yeah.
So you're always going to have those patients. So yes, we do have some patients like that. We already know our patients' personalities. So those are the times we've booked a little bit extra.
Yeah.
And then I will actually modify the mock-up with my handies and stuff right in the patient's mouth. I'm not taking it off. I'm going to modify. I'm going to use composite, flowable composite or something to get it to the way that they want.
Sure.
And once they've given me an aesthetic approval,
Yeah.
just to make sure that this is the one that they approved, we scan it.
Yeah.
And then so this is now the blueprint that's going to the lab.
Okay.
So we kind of get it very close to where.
Yeah, interesting.
Yeah.
See, being so focused on the ortho and the biomechanics, sometimes these things that are happening with the restorative side, they're behind the scenes for me. And so I don't know all the workflows. So this is actually fascinating to hear how this is occurring. So at this point, you've finished the mock-up. If they don't like it, you might adjust it. You know, it'd be super cool. And I wonder if it'll be at this point, and especially with exocad and other options, of being able to then submit for like a refinement or revision even, and then not moving the teeth at all on it, but making the adjustment to the shape of because you can do all of that in Smile Architect.
Yeah.
You could then go ahead even on the spot if a line will have it done fast enough where you could then go ahead and modify the mock-up so you could just take that off and then put on another one.
Exactly. That would be awesome. Yeah. And I know a few things are happening behind the scenes. So we're hoping that would be the next step. But yeah, it's really, really neat. And then I use the mock-up. I keep the mock-up on the patient and I prep through the mock-up. So that's my guided prep, because now I know I can be minimally invasive.
Well, let's take this back a step. So you've got the mock-up on right now, and you prep through the mock-up. Explain that more.
So now the mock-up is where the final restoration is, right? Now I want to peel back, right? Rather than cutting the tooth to add something, I already added, and now I'm just cutting back what the lab's going to add. And at the end of it, I'm going to keep as much.
So you just do your reduction of whatever point,
depth cut first.
1 point, whatever your depth is.
Yeah, exactly.
You go through your mock-up on all, let's say you're doing 8 anteriors.
Yes. Yeah. Okay. So you just go through for the incisal edges and then the buccal. And once I've had that, on the palatal and the interproximal, it's going to be mainly you, because you want to know where is your contact. Yeah. Do you have that triangle or not, right? And then the lingual is, where do you want to place your margin? That's, because with Invisalign Smile Architect, when you design these restorations, everything comes as crown, right? We don't have the options of picking, is it a veneer? Is it a bridge? Is it an implant crown? Is it a regular crown? Yeah. So really, when I'm depending upon these mock-ups or this restorative design from from Invisalign Smile Architect, is for me to guide my preps only buccally and incisally. And then the interproximal and palatal is according to our clinical judgment. Of course.
Yeah, it makes sense. Making sure you have the clearance. That's fascinating. I've never heard of. I'm going to have to start asking around now, because is this something that everybody is doing, or is this a Lovedeep special?
Maybe I should say it's Lovedeep special. No, it's not. I'm a SPEAR graduate, and now I'm in the process of getting my course graduation or qualifications done. Yeah. And one of my favorite teachers is Dr. Robert Winters. Okay. That man's a genius, restorative genius. He's a master ceramist. He's a prosthodontist. It's just the way he does all his preps the same way. So he does the mock-up, he peels them back, and he does it under microscope. So, well, I haven't gotten to that extent yet. It's like, there can be only one Bob Winters, but this is his method, and I've learned from him for years, and so that's why.
That's so cool. Yeah. Okay. So you've done the preps now, then you're going to be making your temps, and do you already have you're just making temps then off of your suck down?
So you have multiple options there.
Yeah.
If your team is equipped and you have the time, you can quickly scan your preps now. And while you're getting everything else done, you can actually use your iTero design suite and design your temporaries and actually print your temporaries if you have a 3D printer. It doesn't take very long, and you can just.
Is that what you're doing in your practice?
I don't do it as much because for me it's the restorative design that I have for Invisalign Smile Architect. It's hard to replicate that yet, and that's my other request to Align. If it would be possible that there's a way that we can actually copy that right into our iTero design suite. Right now, if I do that, and it's a case where it's very important that I keep the restorative design the same because I've already done an SX. I have everything ready to go for this patient.
Yes.
So for me, I still do Luxatemp or Integrity with my.
So you're making the Essex before they even come in, before the preps, to the position of what your final restorative result would be with.
Because I already have the model. So I have the model, I have my template ready.
Yeah.
And then I have my Essex ready.
Yeah.
And I do the mock-up, I prep through it, I do my temporaries, and I give them the Essex, and they go home.
Yeah.
And so the Viveras will come once I've done the final restoration.
Yeah, of course. And then you just scan them again once that's finished.
Yeah.
That's very, very slick because, a common problem. So talk to me about your workflow when you're doing bonding. Are you doing layered technique where you're building it up yourself? Are you doing injection? What's that flow look like for you?
So for my associates, they like injection molding. So that is why we do the same thing. We print out a model and we have the template ready. I'm still old school, step by step, free-handed. Yeah. And that's what I enjoy doing because it's like so exciting to create that. So I do layer by layer, freehand. And I actually, this is one thing, and I don't know if you agree or not. I don't want everybody to have like very symmetrical looking. Like I want balanced occlusion, but teeth to be way too symmetrical and way too piano teeth are like, mirror copy of each other.
Yeah.
It takes away from the personality of the patient's smile. So free-handing it adds that a little bit of where they're going to be very similar. Yeah. Yet there's going to be those qualities.
I think probably so many dentists listening to this will say the same thing, that the statement of our goals for you is not to be perfect, it's to be natural.
Exactly.
Christian Coachman always would say that our goal is natural beauty rather than perfection, because perfection in many circumstances looks fake. And so that's why we don't have blindingly white, paper white or snow white teeth, of course.
Yep.
And why Mexican crowns showing back up that are all flat across all of them with no embrasures and no anatomy, no stain. They're not natural. So makes perfect sense. And then you would make an Essex just right after they get the bonding done to make sure nothing shifts.
Yes, exactly.
Are you making an Essex then between that time frame? If you're ordering a Vivera, would you make an Essex right away and then you'll get the Vivera a week later?
Yeah. So if I'm doing freehand, if it's injection molding, it's already
got it. Essex made already. Yeah.
Yes. So if I'm freehanding it, then we scan the patient.
Will you make a Vivera off of the? Can you make a Vivera if you're doing injection molding or you're doing?
No. So no.
You have to make an Essex no matter what.
So yes, but what happened? Actually, yes, that's true. So sorry. Yes. So in both cases, we do because we make the template. So I forget sometimes because this is so funny. You put systems in place and then you forget because you keep doing it and you're not there doing it.
Preach.
Yes, Essex is made for every patient, and we give them the Essex.
And then because when you scan with the Vivera at the end, like what are we talking about? It's gonna make it so much more ideal because it's going to fit perfect to whatever was done. If there was a slight discrepancy between what was planned and what's done. So one of the things that we'll do when we have a situation where we're building up the incisal edges with bonding is we will take a burr and cut out the tray. So then that way we can build up those incisal edges and the tooth just pops through. Now, obviously, if you're doing all of the anterior teeth, that's not going to work. But if we can just do a few of those teeth, then it can hold over until we get in either a new series of aligners if we're tweaking or into final Viveras or Essex or whatever it's going to be.
Yeah. So. And you know what, Stephen, even with the best laid plans, sometimes things happen. And in dentistry, it happens quite a bit. And so in my office, I remember that we did a big case. We were tired at the end of the day. And we realized it was 10-unit case on the upper anteriors. And my staff forgot to make the Essex. And so now it's like, okay, how do we do it? But luckily we had the template. So I just said, it's not the strongest thing. It's not going to hold long term, but it's like, okay, at least we can do 12 hours, 24 hours. And by tomorrow morning, when we come back to the office.
When you say template, you're talking about the template from actually doing the try-in.
Yeah.
Okay. Is that a lot thinner than?
It is a lot thinner.
Okay.
It is a lot thinner. And that's why it's not something that the patient's going to be able to hold.
Right.
You can't retain teeth with that, right?
Yeah.
But at least it's something that, is going to be there, a little bit of a protection.
Sure.
And so my team, my assistant was very happy that she got, I wasn't making her do that at the end of the day. So next morning, she came in, did the SX, and I think we had the patient pick it up by 10 o'clock next morning. So,
right.
So things happen sometimes.
Yeah, you've got to, orthodontics and dentistry for that matter too, is just literally troubleshooting through problems. So we do construction in the mouth. Yeah. It's let's lay the foundation in the right spot. Let's build on top of that. And we need to troubleshoot just like the contractor working on our pool right now has to troubleshoot different things. So it makes a lot of sense. And so one thing we do in our practice, I don't know if you're the same. So are you taking off attachments the same day that you're doing the actual try-in then? Or do you take off the attachments and have them hold just in a blank tray or a tray with attachments, but there's no attachments on? What do you do?
Yeah. So usually the last 4 passive aligners that I have, or 2 passive aligners that we have, if we're going to do bleaching or something for this patient as well, if we're doing bleaching, I remove the attachments after the active aligners are done. Mm-hmm. And then we give patient take-home bleaching. They do the bleaching, they come in, and by the
And are you doing custom bleaching trays, or are you using your Invisalign aligner for it?
Invisalign aligner for it.
Totally. Oh, yeah, 100%. Yeah. Oh, yeah, no.
You have
that's
to
what
make things, So
So
that's what we do.
Okay.
And then if this is the case that we didn't have to do any bleaching or anything, really it comes down to time. If the team member has the time, we try to bring the patient in a week prior to the restorative, make sure everything's in order, the insurance claims, the financial agreements, everything. And then the team member will probably remove the restorations, take the final pictures of post-ortho. Right. And if not, then on the day that we're going to do the restorative. Now, mind you, if you're going to do 12 preps, removing attachments that day, it's going to be hectic, right? It's adding on to the appointment time. So really, it would be advisable to remove it beforehand, but it's just like you have to kind of make it work in the office.
So we're a little different. And this is where I think the beauty of orthodontics and restorative is there's so many different styles and techniques and flavors.
Yeah.
So I was saying with Summit right now, there's a flavor for everybody, right? There's like more airway specific, more TMD, more aesthetic, anterior, more mixed dentition, every flavor. So we found with some of these significant deep bite cases that as we're intruding the teeth and leveling our gingival margins, if we took off the attachments for too early, 2 things happened. Sometimes patients were very like, yay, I'm out, hooray. And then they weren't as motivated now to actually finish off that last step. But also we noticed then if they did take 2 weeks, 4 weeks, 2 months, 4 months, 6 months, and they're just holding in some temporary trays, that the vertical that we had worked on to get their gingival margins lined up, they take 6 months to figure things out. And then all of a sudden now gingival margins, the tooth is extruded because there's no attachments on that tooth or the neighboring tooth. And so what we've actually done is we will actually wait in our patients while they still have their attachments on. So we don't take them off. Okay. We whiten them with the attachments on, and we'll actually remove all of the attachments the same day that the restorative happens. A bit different, of course, but what I found in our clinic is because maybe our patients need a little bit more motivation and they're more likely to stall. Yeah. If they're not going to do this, that's fine. We'll go ahead and we can take everything off and we can go into your final retainers. But if you are in a situation where you're wanting to do this, which most of them are, it kind of gives that extra motivation. Like, we can take your attachments off once we're ready to go ahead and build up those teeth with bonding, or veneers or whatever it's going to be. And so I found that for us worked really well in our clinic. But I know definitely if it was a situation where we have commitment, like the week before, like you're saying, or even earlier, if you know that they're moving ahead, it certainly reduces the number of things that need to happen at that appointment, because I don't have to do any of this stuff. So I don't have to manage the 3-hour appointment. So I'm like, yeah, take the attachments off at the same time. No big deal. But
yeah. And I agree. Like if the patient is still thinking or on the cusp and saying, I don't know if I want to do veneers or bonding, and we don't have like a set go date, I wouldn't remove attachments, because then it's safer for me just to do another refinement for the patient and to do a little bit more improvement while we are waiting, right?
Totally.
Then I would not remove the attachments. Yeah. But because I do the restorative, sometimes it's like, you're 4 hours in the patient's mouth,
Yeah,
right?
and I'm probably also, because then I don't have to take the attachments off because I'm like, oh, Dr. Cho, who's amazing, she'll take the attachments off at the same time. Yeah. Okay, see you later, bye. But yeah, no, I love that. So tell me one thing.
Mm-hmm.
You finished all of your spear and you're doing all the coist now. Like, that's dedication. What was there? Was there a specific component that you were like, I really want, like, and coming from the world of occlusion,
Yeah.
And having fully done all your spear training, is there one thing where you're like, ooh, I know Kois is like, this is his thing that I really, really want?
I think and again, spear is very comprehensive and interdisciplinary as well. And that's where I learned, and that's what built my confidence to bring different aspects of dentistry into one treatment plan. But now with Kois, for me, the airway, the ortho, like, again, interdisciplinary, but to an extent where I think I can do a lot more with it, is also modification. Other thing is, I get bored if I'm not taking these courses,
Yeah.
right? So it's like, and I have a fear of missing out as well. What is, because dentistry
are you the oldest child in your family?
I am.
Oh yeah, totally. Right? It makes sense. Yeah.
So it's like,
Have that oldest female child, FOMO.
Yeah. So say,
a people pleaser.
People pleaser, of course. Yes.
Yeah.
I still think I'm working very hard on making my dad proud of me. But,
Yeah.
but
See, I'm the youngest, and so I'm just like, whatever, I don't care.
Yeah, no, for me, and again, as you had said before, we don't want to be in 2050 and doing 2020's dentistry.
Totally.
I don't think that 2004 dental graduating UBC, I don't want to be just using that and practicing, right?
Totally.
And I've done spear, I've audited the workshops, means, of course, they put up a new course. I'm going to love going back there. And now it's like, I also want to hear from Kois. What is different? What is his thought process? And a little bit more expand on airway as well is where I'm going. And again, they're evolving these courses as the new technological advances happen in dentistry. Other thing that I'm hoping, and I haven't, done much of Kois yet, when I was doing spear, it was more analog based. And I've had these conversations with Bob Winters too. And I'm like, so when you're saying this, in my head, I'm converting it into a digital workflow because I've been digital since 2012.
Yeah.
So I'm like, I'm just converting it. And I'm looking forward to seeing how Kois is laid out, like, how much of the digital integration is already there so that it can actually make things more simpler for me.
Totally. And maybe a bit of a shameless plug here, but you talk about, I guess, your experience with Clearly Aligned and Clearly Select, and like, how does that play into this dynamic of a hard-hitting CE junkie who goes all over the world to go learn? Can you talk a little bit about that impact or lack thereof? I don't know what she's going to say. I'm not paying her anything, but like, you want my watch? Here it is. Like, what do you need?
So, okay. But I knew you before this, right? And just knowing you and seeing what you did, what you were doing in your practice and how you helped me set up not only my daughter's case, my son's case, but also Mark Stevens' son's case.
Yeah.
And these are my first guinea pigs of mixed dentition and teens. And see how you approach those cases and how you explained all that to me. And I was like, oh my God, I have so much more to learn. Like, I always knew you were this Canadian genius, but just to kind of have that connection with you and just go, you opened my eyes to something that I wasn't aware of, right? And by this time, I had been doing only adult ortho since I did re-engage in 2017, which was amazing for me. But then now not only that these parents were coming in with their kids, and I'm sitting a recall exam, and I can see the child's mouth, and I can see what happened to the parent. And I'm thinking, if I can do something now, intervene now, kid does not have to go through what their parent went through, right? And then talking to the parent, and parent having that trust in me that I could deliver, amazing ortho-restorative results to them, why don't you do it? Well, I don't have enough knowledge yet to do it. So really, taking all your courses online. It was Clearly Aligned before anything else happened. Remember all your courses online?
Absolutely.
Bought the whole package. I was like, this is how I'm going to learn. And then just starting to, then this came on, Clearly Select happened. And I was like, oh my God, this is awesome. The study clubs, the courses that you put up, right? So what it is it's not just the workflows or something, or this is what it is. You bring almost comprehensive dentistry into how you teach. So that's what I love, because it is about, okay, if you have an impacted canine, fine. And this is how we're going to treat it, right?
Mm-hmm.
If I had a case where things didn't go so well, and this is why it didn't go so well. And then the gears are, oh my God, yes, now I know that friction is a big killer. And you kind of hear about it, but didn't really understand it to the same extent. And TADS use and all that means it's just really, if there was an interdisciplinary approach within ortho, that's what you help us see, open our eyes to that. And and I've learned a lot. Thank you so much.
You're making me blush over here. Okay, here's my watch. Jeff will give you 100. Okay. No, it's my passion. And I think that it's so rewarding, especially for doctors that I've worked with for a long time and been able to have that impact, to see how we view the world differently.
Yes.
Right? It's that, starting off with more basic things allows us to now branch and to grow and to accomplish more. And that's the goal of going from just clearly aligned courses that anybody's coming to then the clearly select community,
yes,
where it changes the dynamic from just receiving, here's the information, now go figure it out yourself, to working directly with doctors on a daily basis and being in their practice virtually to support them, helping with case designs directly on their cases,
yes,
and then also providing the sense of community. So it's so cool. Like, if you had told me that 8 years ago, I'd be sitting here having a podcast, right? Working with doctors that are amazing clinicians, but also my friends.
Yeah.
Like, what an amazing opportunity that doing these procedures can do. And then also working less and making more money while we're having such big impacts. Like, we're so fortunate.
We are so blessed.
Yeah.
For
sure. So, and for those who haven't checked her out, come see Lovedeep speak. She's speaking all over the place now and giving more direct pearls for doctors. So I can say unequivocally that you have to go check out her content and see her speak. And if you ever have a chance to see her in person too, just a lovely person, one of the biggest smiles and best laughs ever. So, okay, now you need to give me a Rolex or something back for all those comments.
Well, I have a Michael Kors watch that I bought a long time ago, and I thought that was a very big purchase. Here, you can have it. It means a lot to me.
Yeah, for sure. But thank you so much for doing this. It's just a pleasure.
Thank you. Thank you, as always. And I'm just so excited for what's to come and looking forward to Illuminate.
Yeah, absolutely.
Illuminate.
Awesome.